Hello, my name is Brian Frier. I'm Honorary Professor of Diabetes at the University of Edinburgh in Scotland. And today I'd like to talk about the newer technologies which have now emerged, which we can use to identify hypoglycemia. These are my disclosures. And if I can start with talking about how normally people will detect hypoglycemia, and they usually rely on symptoms. Now, the problem is that symptoms are subjective. They're also idiosyncratic. They differ between each individual. They're age specific. We get different symptoms in young people as opposed to older people. And they're inconsistent. They don't replicate from one event to another. And the other problem is they change over time. And I'll show you that later in the talk. So hypoglycemia is often asymptomatic and is therefore occult and is not easily detectable. And it's particularly difficult during sleep, and that's mostly at night. So awareness of hypoglycemia is a problem, and it can be impaired as part of a syndrome in which low glucose is common and is frequently undetected. So if hypoglycemia is occurring, biochemical confirmation is desirable. And identification of an asymptomatic hypoglycemic episode really depends on how frequently the testing of glucose is being performed and how it is measured. Now, I'm old enough to remember the days before capillary blood glucose monitoring. I can remember having to do urine testing for regular monitoring, which of course is pretty useless when it comes to hypoglycemia because the urine glucose is usually negative. So when the development of capillary blood glucose came along in the late 1970s, this was a major step forward. It was a light year change in how we could monitor and measure glucose. And it made patients able to measure their own glucose at home. This is an example of an early glucose meter. There's a whole range of glucose meters which became available, and many are now used in regular clinical practice. Of course, they do need to be calibrated, and capillary blood sampling is uncomfortable. It's painful because the patient has to prick their finger. So if we look at self-monitoring using capillary blood glucose obtained by a finger stick, and this shows some of the samples here. These are examples in the black boxes here of glucose done using this method. And the green area is normal glycemia. If you looked at this in a patient's profile, you'd think, oh, they've got very, very good control. But of course, if we then use continuous glucose monitoring, you'll see that the glucose is actually fluctuating considerably through the day. So we miss the high figures with these finger stick tests and also the low figures. And of course, the problem is that many hypoglycemia events occur during the night, such as this one here. So we've now got various other ways of measuring glucose in a continuous form, continuous glucose monitoring and flash glucose monitoring. Let me just show you on this slide the various advantages and limitations of these methods. With self-monitoring of blood glucose, this is using finger sticks. It's very familiar. People recognize how to do this. It's generally quite accurate, particularly between 4 and 15 millimoles per liter. Less accurate in the low range or a high range, but it's also relatively cheap. The limitations, of course, are its inconvenience. It can only be done sporadically, so it depends on the number of tests being done. And of course, as I've said, it's both painful and antisocial. It's difficult to do this in company. Continuous glucose monitoring, on the other hand, has the advantage of giving a full glucose profile, which is real time. You get the information immediately. It has an alarm system for hypoglycemia, and it has a connection for an insulin pump. The limitations of continuous glucose monitoring are the cost. It's an expensive method of measurement. It requires calibration, and it also requires interpretation. And that's where, of course, clinicians become important. They are more experienced at looking at these profiles and giving patients advice. So patients themselves may not be able to use this as effectively. Flash glucose monitoring has the advantage also of giving full glucose profile. This is using intermittent scanning every 5 minutes. It doesn't require any calibration and is much less expensive than continuous glucose monitoring. The limitations in the first generation is there's no alert system, there's no hypoglycemia alarm. Now that has been introduced in the second generation of devices, which are just now really becoming commercially available. But there's no insulin pump connection, so it can't be used with closed loop type of administration of insulin. Just a few words about target ranges. Now, the target range is generally between 3.9 and 10 millimoles per litre, or if you want to use milligrams per deciliter, 70 to 180. Below range is usually looked at in either two levels of hypoglycemia. Level 1 is less than 3.9 millimoles per litre, 70 milligrams per deciliter. Level 2, which is true hypoglycemia, is less than 3 millimoles per litre, or 54 milligrams per deciliter. This level 1 is now regarded as an alert level and not true hypoglycemia. Above range figures, level 1 greater than 10 millimoles per litre, 180 milligrams per deciliter. Level 2 greater than 13.9 or 250 milligrams per deciliter. And then, of course, you can get into the problems with diabetic ketoacidosis. So these are the terminologies that are now being used in terms of target range, below range, and above range. And here's an ambulatory glucose profile. This is the target glucose range here, shown between these two lines here. This is the sort of profile that one gets during the day. And the time in range is defined as the percentage of time that a person with diabetes spends within their defined target glucose range. Now, this is a good indication of overall control of glucose, glycemic control. It also correlates well with the risk of microvascular disease. What I'm particularly interested in today is hypoglycemia, and that's time below range, and that can quantify hypoglycemia. Time above range is an indication of hyperglycemia. And you can see there's a median line here, and that the shaded ranges show the 25th to the 75th percentile, or if you look at the outer range, from the 10th to the 90th percentile. Now, I'm not going to discuss examples of this today from individual patients, but I wanted just to show the background information. And the interpretation of this really requires 14 days of continuous glucose sensor data. And that gives you an optimal estimation of overall glucose control. And that should include 70% of the sensor data from within this time period. So this ambulatory glucose profile can be used to identify trends in glycemic control, and that includes both the problem areas, the ones that require attention and remedial action, and the parts of the day where the patient has achieved good control, which allows observation of their self-management decisions that have enabled them to maintain the glucose within target. So there's an educational part to this and a learning exercise from observing these particular results. The international consensus to define hypoglycemia, the target is to aim for less than 4% of readings below 3.9, 70 milligrams per deciliter, or less than 1 hour below the range, and less than 1% of readings below 3 millimoles per litre, 54 milligrams per deciliter, or less than 15 minutes in a day below range. In high-risk individuals, we're aiming for even fewer of these figures, less than 1%, less than 3.9, or less than 15 minutes below range. These are pretty difficult targets to achieve, but that's what the international consensus is now reckoning we should be aiming for. So let me turn to the methods that are now available. First of all, there's flash glucose monitoring. The only one available is this one, Freestyle Libra, made by Abbott. It's a disposable low-profile sensor. This fits usually on the arm, though it can be used in other parts of the body. Sensor lasts up to 14 days. It's factory calibrated, so there's no need to do this by the individual. It automatically measures and stores glucose data, and a quick scan of the sensor will collect and display the glucose data, and it shows the trends and the patterns. It shows the direction of travel of the glucose, whether it's going up, down, or staying stable. It can be used with a smartphone. And here's an example of a well-known individual. This is our former British Prime Minister, Theresa May, who developed late-onset type 1 diabetes in 2012, and she has no compunction about wearing this in public and showing it as a fashion accessory, I think, on her arm. But this is such an easy thing to use that many people have found this an enormous benefit to their self-management of diabetes. The data looking at this prospective randomized trials, there are two major ones that have been done in Europe. Impact is the one in type 1 diabetes, Replace is in type 2 diabetes. And in both of these studies, the time below range, that is effectively within hypoglycemia, was significantly lower when using this device. I've shown the results of the two studies here. Impact is on the left, Replace is on the right. This shows the time, or the change in time in hypoglycemia. Here's on this side of the graph, the change in time in hypoglycemia from baseline in hours per day. You can see a significant reduction at levels of 3.9, 3.1, or less than 2.5. So they stratified it in 3 levels of hypoglycemia. And in particular, if you look at the lower part here of the figure, this shows the percentage reduction versus the control using SMBG. It's particularly striking, of course, for the lower figures for less than 2.5 millimoles per liter. In Replace, they're not quite as dramatic, not quite as substantial, but again, there's definite improvement, less time spent in hypoglycemia, 3.9, 3.1, 2.5, and again, shown here, the reduction versus control, particularly effective when you get down into the true hypoglycemic range. An interesting observation with flash glucose monitoring is that the more frequently the individual does the scan, then the better their hemoglobin A1C tends to be. This is a big study, 50,000 people, readers. You can see the very large number of sensors. This is a worldwide study. And you see the more scans are done, the lower the A1C. And also the less time spent in hypoglycemia. This is using 3.9 millimoles per liter, the alert level. You can see that more scans that are done, then the less frequent the hypoglycemic events. So this is real world data, higher rates of scanning associated with improved glycemic markers, including an increased time in range and reduced time below hypoglycemia and above range. Now, continuous glucose monitoring, I'm going to use the example here, the most recent version, Dexcom G6. There are other CGM devices, or Medtronic, Guardian Connect, combination pumps, Minimed, Paradigm, Tandem. I'm not promoting any particular one here. I'm just using this as an example. Disposable sensors last for up to 10 days with this device. No calibrations required. Automatically measures and stores glucose data. And the display device can be Apple or Android compatible smart device, or a touchscreen receiver, which will show, again, real-time glucose data. And again, this gives us an immediate analysis. You can see the trends and the patterns, and there's an alert system on this one. It shows an impending low glucose of less than 3.1 millimoles per liter. These are examples of the devices shown here. Now, there are many studies, and in fact, there are several coming out at regular intervals now, so much so that I couldn't possibly describe any of these in detail. But fortunately, there's been a meta-analysis done this year. 15 randomized controlled trials have compared CGM with the usual monitoring, and this reviewed parameters of glycemic control in 12 studies in type 1 diabetes and 3 in type 2 diabetes. Now, I have to say that the efficacy of this procedure, this device, is mostly seen in people with type 1 diabetes, but I think as more people are using insulin with type 2 diabetes, this will increase in frequency of use in that group. First of all, it's important to note that CGM overall produced no real change in A1C. So it's not being used to improve glycemic control. The weighted mean difference from all these studies was very small. What it did do, though, is it produced much more time in the target range. In the course of a day, there was more than an hour of greater time in the target range. And this is the real crux from the point of view of this study, it produced a significant reduction in time below range. So both 3.9 and 3 millimoles per liter, these two levels of hypoglycemia, it showed a significant reductions in these periods, in these levels of hypoglycemia. It also showed a reduction in the coefficient of variation, which suggests strongly that glucose variability is being reduced using continuous glucose monitoring. Now, I've shown here a well-known example of how there are two different patients here. The top one, patient A, has high glucose variability. Patient B has low glucose variability. The important point is, of course, that both of these patients have the same hemoglobin A1C. They both have an A1C of 8% in the old money. This shows the blood glucose levels. The dotted line is the average glucose, and you'll see the average glucose in both these patients is the same. But when you use continuous measurement of glucose, it shows the variability during each day and from day to day. And variability of glucose is a major determinant of hypoglycemia risk. It also, of course, shows that hemoglobin A1C is not a good index of hypoglycemia risk. So the question is, can we use CGM to enable glucose targets to be achieved and also to actually try and eliminate or eradicate hypoglycemia? Well, this is a study published this year in Diabetes Care. It's called the GOLD crossover trial. These were adults with type 1 diabetes, 161 people, treated with multiple daily insulin injections, and they were randomized to continuous glucose monitoring, and this was using Dexcom G4, or conventional therapy with self-monitoring of blood glucose. They did this for 16 months. So the association was assessed between the time spent in hypoglycemia and various mean glucose levels and also hemoglobin A1C levels. Overall, with the lower levels of mean glucose and of hemoglobin A1C, the time spent in hypoglycemia using either 3.9 or 3 millimoles per liter increased significantly, whether they were using CGM or conventional therapy. So if you tighten control, if you give them stricter control, there's no way we're going to avoid getting more events in hypoglycemia. But let's look at this in a bit more detail. Here's the glucose levels. This is the different glucose levels, mean glucose levels. And this on this side is the percentage time of glucose values. I've taken less than 3. I've taken the true hypoglycemia, but there are data, of course, for 3.9 as well. And what we're seeing here is the green here is baseline data. At the end of conventional therapy using SMBG, it's in orange. At the end of CGM treatment, it's in blue. And if we look at this carefully, there was less time spent in hypoglycemia, less than 3 millimoles per liter, using the CGM compared to SMBG. If I take the level here of 8, this is a mean blood glucose level of 8. The mean percentage time was less than 3% in the people on when they were on SMBG, whereas with CGM, it was 1.7%. So less time spent in hypoglycemia using CGM than using SMBG. But look, we're not eradicating hypoglycemia altogether. If I turn now to hemoglobin A1C, and this is the mean hemoglobin A1C in millimoles per mole along the lower part of the slide. Again, this is the percentage time of glucose levels less than 3 millimoles per liter. Again, the same key here. Green is baseline, orange is conventional therapy, and blue is the CGM. The lower the A1C goes, the time in hypoglycemia increases. Again, irrespective of whether we're using CGM or SMBG. But if we take here the mean hemoglobin A1C, 52 millimoles per liter, that's 7%. You have less time spent in hypoglycemia using CGM than with SMBG. The difference here is 1.5 to 3.5%. So this again shows the benefit of CGM as opposed to conventional SMBG. So this trial shows that it was significantly greater, the time spent in hypoglycemia was significantly greater at lower levels of mean A1C and mean glucose, irrespective of which form of monitoring we're using. But the CGM was associated with less time in hypoglycemia than self-monitoring blood glucose at lower mean glucose levels and over a broad range of hemoglobin A1C levels. They make the point, and the authors make the point in their paper, is that it's very difficult for people with type 1 diabetes who are on multiple daily insulin injection to achieve these current targets. They're trying to limit the time spent in hypoglycemia while also reaching the A1C targets. And that's difficult irrespective of which form of monitoring is being used. The final point, I suppose, is CGM has the edge over SMBG in this respect. The final section, let me look at impaired awareness of hypoglycemia, because this is a major problem area. As you're well aware, it's particularly a problem in type 1 diabetes. About 1 in 4 adults with type 1 diabetes have this syndrome, less than 10% with insulin-treated type 2 diabetes. This is an old study from Steve Pramming in Copenhagen, where he showed that the longer people have diabetes, type 1 diabetes, the greater the risk of developing severe hypoglycemia without warning. So they get no warning symptoms. And as I said right at the start of my talk, the symptoms of hypoglycemia change over time. You get fewer and fewer autonomic symptoms, and neuroglycopenic symptoms predominate. If somebody develops this syndrome, the risk of severe hypoglycemia is up to 6 times more. And I define this as the diminished ability to perceive the onset of acute hypoglycemia. It's the onset that's important. Many people with this condition do develop symptoms, but by the time that these emerge, they're severely neuroglycopenic and they can do nothing about it. So here's the benefit of using continuous glucose monitoring in people with impaired awareness. This is a study that Pratik Chowdhury did in London. He did a retrospective audit of the use of CGM for more than a year in 35 adults with type 1 diabetes, all of whom had impaired awareness of hypoglycemia and were either on pump therapy, CSII, or were on multiple daily injections. And what you can see here is that the rates of severe hypoglycemia, and that's any episode requiring help for recovery, they declined substantially, dramatically over the course of the year, from 8.1 down to less than 1 episode per year. So very impressive change when you use CGM. However, although the A1C declined somewhat as well, there was absolutely no change in their hypoglycemia awareness. So at the end of the 12 months, all of these people who had impaired awareness still had impaired awareness. Here's another study. This one is the in-control study from the Netherlands. And this was a randomized crossover open label trial, 52 adults, all of whom had impaired awareness. And it compared real-time CGM with self-monitoring of blood glucose. They were randomized to 16 weeks of either form of treatment, separated by a 12-week washout. During the self-monitoring blood glucose phase, they did have a masked CGM device, but they had no access to that, so it was unable to influence their management. And the primary endpoint was the mean difference in percentage of time spent in normal glycemia. Here, from 4 to 10 millimoles per liter over the total intervention periods, and this was analyzed on an intention to treat basis. Secondary endpoint was the frequency of severe hypoglycemia. So there were 2 sequences. You either started with CGM and went to SMBG, or the other way around, started with SMBG and went to CGM. What is clearly evident is that when the patients were using CGM, the time spent in normal glycemia was much higher. When they switched over to SMBG, it dropped, or went the other way around, SMBG up to CMG, you see CGM, you see how the time spent in normal glycemia improves. So there's the difference, 65% versus 55% is statistically significant. Much more important than that, from my point of view, is the number of severe hypoglycemia events. Here are the ones patients when they were in the SMBG part of the study, the phase, and this is it in CGM. Quite a major difference shown. This is all severe events, 34 versus 14. These are events occurring in coma or seizure, and the very dark colored ones are the ones resulting in admission to hospital. But what is clearly evident here is that with CGM, severe hypoglycemia was less frequent, the time in normal glycemia was increased, but the hemoglobin A1C remained unchanged. A similar study was done in Germany, HypoDE study, 6-month multi-center study in 12 centers in Germany. This is an open label, parallel randomized controlled trial. There were 149 people with type 1 diabetes. They either had impaired awareness of hypoglycemia or they had experienced severe hypoglycemia in the previous year. That's a major risk factor for further severe hypoglycemia. They're randomly assigned to either using real-time CGM or using conventional self-monitoring of blood glucose for 26 weeks. And the primary outcome was the number of hypoglycemia events with a glucose of less than 3 millimoles per liter for 20 minutes on CGM. So the mean number of hypoglycemic events for the 28-day period in the real-time CGM group was reduced from 10.8 to 3.5. No similar reduction was seen in the people using self-monitoring. So again, a major benefit here of CGM in reducing the frequency of hypoglycemic events. And this is in high-risk people with type 1 diabetes who had been treated with multiple injections of insulin and who had either impaired awareness or a recent history of severe hypoglycemia. So again, confirming the information shown in the study from the Netherlands. Finally, let me just look at the HyperCompass study. This is a study done in 5 centres in the UK, where they were looking again to see if they could find the suitable methods of managing impaired awareness and trying to reduce both the risk and also try to improve the state of awareness in these individuals. So they compared insulin pump therapy, continuous subcutaneous insulin infusion, with optimized multiple injection therapy. And it's shown here, either injections or pump, with or without real-time CGM. So they're either using self-monitoring or CGM. It was a 24-week 2x2 factorial design. Patients all got the same education, support, therapeutic targets, the avoidance of biochemical hypoglycemia. And the primary endpoint was between intervention difference in hypoglycemia awareness. And here they used the gold score, which we devised in Edinburgh. Here are the results. The time in biochemical hypoglycemia, less than 3 millimoles per liter, decreased from 53 to 24 minutes and 24 hours without any deterioration in glycemic control. So it wasn't a case of the A1C rose, therefore they got less hypoglycemia. They actually reduced biochemical hypoglycemia significantly. Even more important though is the severe hypoglycemia incidence decreased 8.9 down to less than 1 episode per patient per year, as shown in one of these earlier retrospective studies. There was a modest improvement in the hypoglycemia awareness score. It improved from 5.1 to 4.1, but anything over 4 is still significant impaired awareness, so it was not restored to normal. And at 24 weeks, there was no significant difference in outcomes observed when you compared pump therapy with multiple injection therapy, or, and this is the most important part, I suppose, comparing real-time CGMG with SMBG. So in this situation, one was not more beneficial than the other. So recurrent severe hypoglycemia can be prevented in long-standing type 1 diabetes without relaxing glycemic control, without allowing A1C to rise. But the hypoglycemia awareness status can be improved only very modestly, if at all, in these patients. So I'd summarize this flash glucose monitoring and real-time continuous glucose monitoring, CGM, both are effective in increasing the detection of asymptomatic biochemical hypoglycemia. The time below range, which is effectively within hypoglycemia, and the glucose variability can both be reduced using these two methods, FGM and CGM. Continuous glucose monitoring was associated with less time spent in hypoglycemia than self-monitoring of blood glucose over a broad range of hemoglobin A1c levels. And in people with impaired awareness of hypoglycemia, the frequency of severe hypoglycemia could be substantially reduced by using either flash glucose monitoring or continuous glucose monitoring. And while a modest improvement in awareness of hypoglycemia may be possible, it's very unlikely that normal awareness can be restored. Thank you very much.